this deep dive that has been sponsored. The speaker has been sponsored by Takeda. You've seen all the housekeeping video, the scrolling video. Most of you know you wouldn't be here if you hadn't registered. So, but for your colleagues and friends who haven't yet, just remind them each year we need to do a new registration. And then just a plea again for muting yourself if you're not speaking or actively asking a question. And then just to ensure your CPD points that you follow up, that will be done automatically. But just keep an eye on your CPD points. So can we move on? I think this has probably all been done and dusted. I'm not sure if we still are able to submit orders. We actually put our order in separately, but for him 5. And then just outside of this, that's a note for next week. But for those of you who are attending the IMS educational meeting, just a point that it's at the Radisson Blu near the airport, not the Gautrain Sandton Radisson Blu. So just in terms of you don't end up at the wrong conference center / hotel in Johannesburg on Friday. So it's my singular honor to should we move on to the talk to present Prof. Craig Moskowitz. I shared a platform with him at a Takeda Africa meeting late last year, and I can attest to that. He's has a very clear idea and excellent approach to both Hodgkin's, which is involved in research, as well as diffuse large B-cell lymphoma. I'm not going to go through the CV. You've all seen it on your emails, but just to say that he has extensive research and clinical experience in both Hodgkin's and non-Hodgkin's field. And in South Africa, we really are kind of caught in quite a bind because we're going to be talking about advanced Hodgkin lymphoma. That really comprises, in terms of Hodgkin's, most of our patients either due to HIV or late presentation due to poor referral networks and late diagnosis. So it is kind of really a pity that most of our patients do come with advanced Hodgkin's, and we actually, for many patients, lack the funding for therapy, the excellent new therapies that have been brought into the first-line setting. But Craig's going to go through all of that. There's some other interesting stuff that I'm sure he's going to allude to in terms of updates from ASH. So Craig, I'm going to hand over to you, and we look forward to your talk.
Well, thank you very much. Am I going to share my screen or?
Yeah.
Yes.
I think, yeah.
Okay, let me try to do that. Everybody
I
sees
just talk from last year, but I don't think that's going to be what you want to see. I think the updated one would be great.
Everybody can see this?
Yeah.
Okay, I'm sure you noticed my Reed Sternberg background for this lecture, so it might be appropriate as opposed to my typical golf one. So I'm going to talk about things that are important in Hodgkin lymphoma in 2025. I'll give you an update from ISHL and ASH. I understand, obviously, that there are agents that are not necessarily available. We all practice, but my job is to present what the optimal treatment strategies are for these folks. Here are my disclosures. So I got this slide from Volker Deal when he lectured at Sloan Kettering. As you know, I was there for 25 years in 1999. when Biocop just came out, and I always like this Cairo slide, because the German Hodgkin lymphoma study group forever has championed the fact that more is better, and a lot more is better than more. It turns out, however, that for Hodgkin lymphoma, this may not be the case. In certain aggressive lymphoma, large cell lymphomas, it may be, but in Hodgkin lymphoma, giving your most aggressive therapy up front at the end of the day does probably not make more patients live longer. So I'm going to just 3 questions that I think are important in moving the field forward. The first, probably one of the more important, is should radiation therapy be eliminated in early stage Hodgkin lymphoma? The second is Nivo AVD superior to brentuximab-based therapy in advanced stage Hodgkin lymphoma? And lastly, and this is an area I've focused on for the past 30 some odd years, are we overtreating relapsed and refractory patients in the era of novel therapeutics? I personally transplanted almost 1,300 patients with Hodgkin lymphoma, and I'm not overly convinced that that's overly necessary in first relapse anymore. So to begin with, I'm actually not sure we are curing more patients with Hodgkin lymphoma than we did 10 to 12 years ago. With optimal therapy, less patients with advanced stage Hodgkin lymphoma need second-line therapy and transplantation. However, with less treatment for early stage Hodgkin lymphoma and their elimination of involved site radiation, more patients are relapsing. Probably does not impact survival, but it does affect what you're doing. And clinical research has moved in the direction to maintain the cure rate of patients with Hodgkin lymphoma and decrease long-term side effects, which I think is appropriate. But now with our options in the second line, where it's ever expanding, we need to think about using these active agents as part of the initial management. So let's start. Should we stop administering radiation therapy to patients with early stage Hodgkin lymphoma? And I'm not going to go over a laundry list of studies for you all trying to answer these 3 questions. I'm trying to kind of do this in the context of the important research that's been presented or published in the past year. And obviously, patients want to be cured with the least amount of therapy and with minimal toxicity. So I'm a big fan of the RAPID study. It was published now almost 10 years ago. It's probably dated now, but it's still a beautifully designed study where patients with stage 1A or 2A disease, non-bulky, intermediate risk, although about 2/3 of the patients had favorable early stage Hodgkin lymphoma, got 3 cycles of ABVD. Then there was a PET scan, very, very stringent PET criteria, which in retrospect was too strict, where only double scores of 1 or 2 were considered negative. Patients with a score of 3 to 5 received 1 more cycle of ABVD and involved field radiotherapy. In patients who were a PET2 negative, there was a randomization to 30 gray or no further treatment. So I'm going to show you the 16-year follow-up that was presented at ASH. It's a well-balanced study between men and women. The median age is 34. Majority of patients had stage 2A disease, but despite that, the majority of these patients had favorable disease. This was what was published in the New England Journal, where at 3 years, the progression-free survival was about almost 4% better with radiotherapy versus no further treatment. But of course, the conclusions are we're not going to treat 100 patients with radiotherapy to help 4 patients. And obviously, there was no difference in early survival. This is the updated curve, which is not published. At 16 years of median follow-up, there was absolutely no difference in overall survival. If you look at the bottom and you look at the data that are in patients who are PET negative and received involved field radiotherapy, or PET negative that received no further treatment, at 15 years, 94% of the patients are alive in the radiation therapy arm, and 92.3% in the patients who are in the no further treatment. So you would think that this is done. You don't need to be radiating patients with stage 1A or 2A non-bulky early stage Hodgkin lymphoma. This is the causes of the death in patients who are PET negative. And you can see that there's only one death from Hodgkin lymphoma. All the deaths are from other things. In the patients who are PET avid, however, and those are the patients who receive one more cycle of chemotherapy and radiation, there were 7 deaths from Hodgkin lymphoma, but 6 deaths from respiratory failure. So my conclusions of this is at a median follow-up of 16 years, patients who are PET negative have done extremely well. Who, if any patient, should get involved field radiotherapy? So there is a correlative study that was published by Tim Illich looking at the 5-year data in RAPID in patients who were PET3 negative and were either radiated or not radiated. In the patients who had a largest nodal mass of 5 centimeters, there's no difference in outcome. In patients who had greater than 5 centimeters, those patients who are not radiated, in fact, the numbers are pretty small, really had an inferior progression-free survival. So for me, if I'm going to use this program in a patient with a 7 or 8 centimeter mass, and on a caveat, I never do actually, but I wouldn't give 3 cycles of chemotherapy. But if I was going to, I would probably radiate the patient with involved site radiation therapy in that setting. Now, this is from ASH. This is not published. This is from the Alliance looking at BV-Nivo with doxorubicin and dacarbazine in early stage Hodgkin lymphoma. Now, this is arm C of a very large Alliance study looking at 4 cycles of BV-Nivo AD in patients with early stage Hodgkin lymphoma. The patients had stage 1A, 2A, non-bulky, but it could have had B symptoms, so a little bit different than the RAPID study. 150 some odd patients, well balanced. 147 of the 154 patients completed the treatment. Typical median age, a little bit more women. And B symptoms were present in 35 patients. The majority of patients were unfavorable, which is different than a RAPID study, which the majority of patients are favorable. And here's the progression-free survival. There's only 5 progression events at a median follow-up of 30 months. Curves look great. And if you look at the patients with favorable disease, there's no events. That's the top curve. These are the unfavorable patients who are in the orange curve, which is also really quite good. That's where the 5 events were. Overall survival is 1 death. So the conclusion is fairly straightforward, and the results are great. But this treatment strategy is not approved for early stage Hodgkin lymphoma. There'll need to be further studies to be done to look at these novel agents. Now, there is an international randomized study, which I'm leading in North America, which I hope will get done, although I am skeptical, called the RADAR study, which everybody is receiving 2 cycles of ABVD or BVABD. Then there's a PET scan. A little bit less stringent criteria. Levels 1 through 3 are considered negative. If the PET scan is negative, you get 1 more of your assigned treatment, and then you're done. So either 3 cycles of BVABD or 3 cycles of ABVD. If the PET scan is positive, you'll get 2 more cycles of your prescribed chemotherapy and radiation. So this is an ongoing study. We're participating in this, obviously, and there's a couple 100 patients on. Now, for some reason, something's on my screen, but what do I do for patients who are RADAR eligible but are off study? In patients who receive 3 cycles of chemotherapy with negative PET scans, I said I do consider giving radiation therapy for patients with bulky disease, but not 10 centimeters. Now, I lectured just 2.5 weeks ago, and I said BV or Nivo, or this program, BV and AD, should not be used off study. Both Bevo, Nivo, and Pembro are not approved for early stage Hodgkin lymphoma. However, last week on 2/12, and I'm not saying I agree or disagree with this, is the NCCN approved with level 2A evidence that BV-ABD and Nivo-ABD for 4 cycles based upon the Nivo AVD study from the Germans and BV-ABD from the Breach and the program we did from Memorial Sloan Kettering, that these programs are approved. We probably be able to get it in the United States for patients with unfavorable early stage Hodgkin lymphoma. I'm not saying I agree or disagree with this, but it will be in the guidelines. Let's move to question number 2, which is advanced stage Hodgkin lymphoma. Sad but true, my favorite Metallica song, but the era of ABVD is over. Sorry, but it is. For advanced stage Hodgkin lymphoma, which is stage 3 or 4, and I want to remind you, the German Hodgkin lymphoma study group uses stage 2B with tumor bulk. Those patients are included in their studies, are not included in any of the other studies. The choices are, BV-ABD or the Arathil approach, which is PET adapted, escalated BIACOP for 4 cycles. Then there's BRICAD and Nivo-ABD. Now, I have not given ABVD or escalated BIACOP in the 6 3/4 years that I've been at the University of Miami. Should we still be giving BV-ABD is the real question. So the phase 3 studies, a quick story. The first is the Echelon 1, which is patients with advanced stage Hodgkin lymphoma, a very straightforward study comparing BV-ABD versus ABVD. The primary endpoint was a modified progression-free survival. Secondary endpoints were overall survival. At 6 years, I don't have the 7-year curves, which were presented at ISHL, but they look exactly the same as the 6-year curves. There is a 7 to 8% improvement in BV-ABD. I want you to look at this number here, 82.3%. It's important to remember that BV-ABD must be given with growth factors. If you give it appropriately with growth factors, the progression-free survival is somewhere between 83 and 84%. It's required, growth factors are required. What's fascinating and once again difficult to explain is at 6 years, and this was published in the New England Journal, there was an overall survival advantage to BV-ABD. And that story put a nail in the coffin for ABVD in the United States for patients with stage 3 or 4 disease. This became the standard of care. It's actually the only study that I know of in Hodgkin lymphoma, other than comparing escalated BIACOP to COP-ABVD, which of course is ancient history, where there's an overall survival advantage of one program over another program. Well-balanced study, obviously, growth factors are important. So to me, BV-ABD is the clear winner. Is it still the standard of care? So this is BRICAD. Now, BRICAD is the German version of the incorporation of brentuximab vedotin into the BIACOP programs. It's the HD21. It was published in The Lancet 4.5 months ago and presented at ISHL and an updated ASH. It's sort of, I like to call it a remodeling of escalated BIACOP. And for those of you who give this program, basically bleomycin, vincristine, procarbazine, and dexamethasone are out. And brentuximab, dacarbazine, and prednisone are in. Those are the changes. The Kairos backbone, which of course is the way the Germans think about treating Hodgkin lymphoma, remained, which is doxorubicin, cyclophosphamide, and etoposide. So what happened with this program? Well, it's a beautifully done study. Everybody got their assigned chemotherapy for 2 cycles, and there was a PET scan. If the patient was PET2 negative, which was Dovel's 1 to 3, they only received 2 more cycles of the prescribed program, either 2 months of BRICAD or 2 months of escalated BIACOP. So only 3 months of treatment. Now, I will tell you, it may not be the most pleasant 3 months, but it is only 3 months of treatment. If the PET scan was positive, you got 4 cycles of BRICAD additional or 4 cycles of escalated BIACOP. And if there was PET positivity at the end of treatment, you were able to give what I like to call mop-up radiation therapy. That happened 11% of the time in the patient population that got 6 doses of their prescribed chemotherapy. No biopsy was done prior to giving that radiation therapy. The patients were just radiated. And this was a non-inferiority study. And once again, surprisingly, it turned out that BRICAD was actually superior to escalated BIACOP. As you can see in these curves, there was no difference in overall survival. What is very interesting to me and my colleagues here at Miami is that if you look at the curves based upon the PET status, actually the top curve here is for patients who got BRICAD for only 4 doses, which means they were PET2 negative, PET4 negative, no radiation therapy. And these patients, pretty much have a progression-free survival at 4 years of 96.8%. Now, hard to know what to say. Those results are truly amazing. And in fact, there is some correlative data to suggest that many of the patients who got 6 cycles of BRICAD probably could have gotten away with 4 cycles based upon metabolic tumor volume. I don't have time to show you that data, but that's impressive in JCO. So what about the United States intergroup study, which compared nivo-AVD to brentuximab-AVD? Obviously, this was published in the New England Journal. We put on 23 patients at Miami in this study, and I'm actually part of the steering committee. So well-designed study, only stage 3 or 4 patients. This is the first study in the United States lymphoma cooperative groups that AYAs were involved, age 12 to 17, and patients older than 60 were eligible. Obviously, in the BRICAD escalated BIACOP study, the cutoff was age 60. We also allowed mop-up radiation therapy to residual PET-avid lesions in this study, but very interestingly, only 3 patients were radiated. So, which in itself is fantastic. So let's look at what happened. So this is what was published in the New England Journal. The 2-year data, which of course still is too soon. You never know what's going to happen. Remember, BRICAD is at 4 years, and BV-AVD versus ABVD, we have 7-year data. This is the 2-year data. It's still remarkable. And look at the BV-AVD data set. It's exactly the same as Echelon 1 at the same time point at 83%. And here everybody got growth factors. So to me, and the overall survival is the same. To me, the subset analyses are the most interesting. This is the data in patients who are AYAs, so age 12 to 17. And I think that you may or may not know, but the radiation therapists give a lot of the pediatricians notoriously have given a lot of radiation therapy to patients with Hodgkin lymphoma for very unclear reasons. So historically, the AYA patient population for advanced stage Hodgkin lymphoma are at the mid-80s from their programs. However, their most recent data set, which is the AHOD 1331, which used brentuximab-based chemotherapy, had excellent results at 92% at a 3-year event-free survival. How does that compare to this intergroup study? Well, there were 240 AYA patients that were randomly assigned to receive either one of the programs. as far as it was well balanced, meaning age is 15. Well balanced between stage. B symptoms are very common in kids. And most of the patients had a little bit more favorable advanced stage Hodgkin lymphoma. Tumor bulk is also much more common in kids, which is why the pediatricians commonly radiate. So outside of this study, half of these 240 patients would have been radiated. If you look at the completion of treatment, children are pretty resilient, so almost everybody received all the treatment. But look here, only 3 of these children were radiated. And this is, if you ask me, this is the second best part of this intergroup study, is the elimination of radiation therapy in advanced stage Hodgkin lymphoma. Here are the results. There's a 12% improvement in the AYA patient population, same 83% for BV-AVD. I'm not saying it's better than the previous program, but it's certainly better than the BV-AVD approach. The previous program includes brentuximab and etoposide. Now, what about the older patient population like me? I'm older than 60. It's not common. About 20% of patients with advanced stage Hodgkin lymphoma. It's almost impossible to give ABVD to these patients, and nobody can get BIACOP. So we need to come up with a strategy. If you look in the echelon 1, about 2/3 of the patients who got BV-AVD did well in patients older than 60 at 5 years. So 103 patients, so a lot less, but it is what it is. So 50 patients in each arm. Median age is 67. Most of the patients were men. As far as adverse effects, when I look at these types of curves, it always looks like one is worse than the other. My take of this is that there's toxicities in both groups. So I'll just say maybe BV-AVD is a little bit more toxic than nivo-AVD in this patient population. What was interesting, though, is that only 28% of the patients who got BV-AVD actually completed all of the treatment in full dose. So either patients didn't want it anymore, or there was toxicity or whatnot. 80% of the patients on the nivo arm received the full intended dose. And here are the results. The results are what they are. There's a marked improvement using nivo-AVD versus BV-AVD. I have like 2 patients right now. I have a lady who's 77, who is on cycle 3B of nivo-AVD, who is PET2 negative. And I have a guy who's 69, who's on cycle 4 of nivo-AVD. They're both doing fine. I will say, though, that I give everybody with nivo-AVD older than 60, I give them growth factors. However, there's an overall survival advantage. So this is number 2. So this is done. This is the program that should be used in patients that are older than 60. As far as deaths go, there were 10 deaths in the BV-AVD arm. Now, there's a subset analysis looking at EBV positivity and negativity, and which is enriched in the elderly patient population. And you can see that if you're EBV positive and you're 67, this looks like this is probably the treatment you really need to get. In the EBV negative patients, the results are the same, but this one is a lot less toxic. So that's my take of this. I think that this is standard of care for patients who are older than 60. So if you kind of like go through the story, if you're going to give ABVD, and I'm not saying you should or you shouldn't, I don't, you need to give a PET-adapted approach. No one wants to give bleomycin. It's cheap, but the other treatments are better. A BV-AVD is certainly better than ABVD. GCSF is mandated. Neuropathy is always an issue. PET scans, I believe, are useful. BRCAD is equivalent or better than escalated BIACOP. 60% of the patients only receive 3 months of treatment. We have data to suggest that probably close to 80% of the patients probably get 4 cycles of BRCAD as opposed to 6. And if you're going to give BV-AVD, which I think you can give, you should give Briquet. Briquet is a superior regimen to BV-AVD if you want to give brentuximab. Nivo-AVD is well tolerated. Inter and PET data is unknown. I get it on everybody. Still difficult to interpret. Short of follow-up, but it's superior to BV-AVD. It is not superior to Briquet, but I do believe it's standard of therapy for patients older than 60. So the last point I want to get through is approaching the second line questions. So this I published a while back in Nature, an algorithm for relapsed and refractory Hodgkin lymphoma. Everybody gets a biopsy. There are risk models that are out there. Everyone gets salvage treatment. The goal is normalization of your PET scan followed by transplant. The pretreatment risk factors are straightforward. B symptoms, extranodal disease, remission duration, being heavily pretreated. These are the Athera risk factors, which I published now almost 10 years ago. I'm not going to discuss that today. I can answer questions on that if you'd like. I think maintenance, however, should be given if you want to do an auto transplant and a CR is not achieved. So the story at the time of the Athera publication on the left panel is in the pre-brentuximab era. About 2/3 of the patients here in blue achieve a PET negative response to salvage chemotherapy. And the rule of thumb is about 70% of the patients that are PET negative at the time of transplant are cured. All the other patients need to get additional treatment. If you're going to give brentuximab with chemotherapy as salvage, the PET negative rate is only a little bit better, and the results with transplantation is about the same. And to be perfectly honest with you, brentuximab is sort of targeted chemotherapy, as you know. So now, as of today, in 2025, the important issues are, did the patient receive BV-AVD as standard of care on a research study? Did the patient receive Nivo or Pembro-AVD on a research study? If the patient had early-stage Hodgkin lymphoma, was short-course chemotherapy alone administered? Did the patient only receive 3 months of ABVD? And what does the relapse look like? Does the patient have stage 1 disease after that? Did the patient achieve a PET negative response after salvage chemotherapy? And what did you do? Did you give brentuximab-based salvage, checkpoint inhibitor-based salvage? Did you give BV-Nivo? Did you give platinum-based salvage? This is my thought process when thinking about patients with relapsed and refractory disease. So this we've published a number of times. And if you look at the PET negative rate to all of these programs here, from ICE chemotherapy, which, I wrote now 30 years ago, to sequential BV and ICE, to BV-Nivo, the PET negative rates pretty much range from 2/3 to 75%. And then if you look at what is the likelihood of being cured, as I said before, somewhere between 70 and 75% or so of patients are doing well. However, in most parts of the world, we give checkpoint inhibitor-based salvage chemotherapy these days. And, there's BV-Nivo, which we wrote. The PET2 negative rate was only 67%, but the progression-free survival is 90% after a transplant. This is the program that Allison Moskowitz and I wrote at Sloan Kettering, which is Pembro GVD, and I'll talk to you more about that. The City of Hope regimen is Pembro sequentially with ICE, and then there's a NICE regimen. But in general, and you can look at the data here, it's remarkable. This data is, if you can get a patient in remission and you transplant the patient, nearly everybody seems to be doing well. Now, this is unpublished. This looks at 1,000 patients that have either received chemotherapy alone as salvage, brentuximab alone with chemotherapy, or a checkpoint inhibitor with or without brentuximab. And you can see the differences here as far as progression-free survival. If I had a relative, I would prefer that they're on this blue curve. So what looks to me now is this is what I showed you previously, and this is kind of what it looks like now. The PET negative rate is very high, and the majority of patients are cured, 90%. And there are very few patients that are left now that need to receive additional therapy, although they are floating around and they are accumulated and they go from research study to research study. So I think now in 2025, you have relapsed or refractory disease. Remember, you always need to biopsy those patients. If the patients are BV naive, I think they should get, in this situation, I must give everybody BV-Nivo. If the patients are a BV failure, I give everybody Pembro GVD. And if the patients have had both, if they're a checkpoint inhibitor failure, I'm giving various treatments depending upon remission duration. So we send them for transplant, and then we look at risk factors and we decide if anybody should get maintenance therapy, which is still apropos if the patients are BV naive. And on a sidebar of the Athera study, nobody can get 16 doses of brentuximab. It's too much, a whole year, especially in patients who are in remission going into transplant. So this is the second Pembro GVD study, which is not published, but will come out in the JCO. And we decided, Allison and myself, we're not related, but we decided that if 90% of the patients are being cured, maybe we're overtreating some patients. So we wrote this study, very complicated program. We gave everybody 4 cycles of Pembro GVD. And then the goal, if you were in remission, was to get a year of Pembro maintenance. We were hoping that this was going to be very straightforward, and was anything but straightforward. And the primary endpoint was freedom from second relapse, because we made the assumption that if patients progressed after this treatment, then we could always salvage them with a transplant and second relapse. So we enrolled 40 patients, and the complete response rate was the same to Pembro GVD, it was 90%. Now, what happened to these folks, which was where the problem started? Well, the 4 patients who had a PR, one went to transplant directly, one patient was radiated and was transplanted, one patient received Pembro maintenance, and one patient received BV-Nivo and radiation therapy. So then one would have assumed that all these 36 patients now should have gotten the Pembro maintenance, but that did not happen. We had 1 death from pneumonitis. Then 11 patients received treatment off protocol. Well, 6 of them wanted to be transplanted anyway, so they took themselves off study. 4 patients had Pembro toxicity, various related, either endocrinopathies or terrible rashes, and then 1 patient didn't want any more treatment. So only 24 of the 40 patients got the Pembro maintenance. But remember, the primary endpoint of this study is freedom from second relapse. And this is what happened for the patients who got the Pembro maintenance. The results are definitely not what we were hoping they would be. At 30 months, 60% of the patients are progression-free, and obviously there's no plateau. So what happened to these folks? Well, there were 10 relapses, 4 during the maintenance, 3 within 6 months of the maintenance, and 3 patients after 6 months of the Pembro. So what happened to these 10 patients? Well, 9 were transplanted, and they got various salvage treatments. And 1 patient got additional chemotherapy, achieved a CR. And so we were very worried that we wrote this study, which took over 3 years to do, which we did at Sloan Kettering and at Miami, and then it was a failure. Turns out the patients who received maintenance, freedom from third relapse, which is what we were hoping for, everybody is progression-free. And of all the 40 patients who we enrolled, we had the one death from pneumonitis, and everybody else is progression-free, either after pembro maintenance alone or a transplant in second relapse. So we do think that the study then met its endpoint. Turns out that when you do prospective studies, you'll learn things. The majority of patients who did poorly had stage 4 disease on this study. We had a concomitant study for patients with very favorable disease, which was pembro and involved site radiation therapy. This was a study we did with our radiation therapy colleagues at Sloan Kettering and at Miami, where we gave everybody 4 cycles of pembro. You had to have stage 1 or stage 2 disease, got chemotherapy alone, and then relapse with stage 1 or stage 2 disease. We gave everybody 4 doses of pembro, and depending upon the Doval score, you can see what happened. We either radiated the patients with 20 gray, or we biopsied the patients, and if they were negative or positive, we either radiated them on higher doses or we took them off study. This was presented, and the resident won an award at ISHL. There were 18 patients. The majority of patients had stage 2 disease. 13 of those patients had relapse disease and 5 had refractory disease. And at 3 years, the median time to progression is 67%. It turns out, however, that the patients with refractory disease did very poorly. Is something like this going to move forward? Probably not. But there are patient populations that may benefit from radiation therapy, especially if they weren't radiated before. Toxicity was well-tolerated treatment program. So Allison and I have written this multi-center study, which is now ongoing. We're giving everybody pembro GVD for 2 cycles, and patients who are in remission will either be get pembro GVD 2 more cycles, or just go to transplant, or they'll go down the maintenance route. And we have a number of centers who are participating in this. I think it's an interesting approach. I prefer a different approach, which, if you want to read it, this is in Nature Clinical Cancer Reviews that we put out about 6 months ago. I think that this one makes a little bit more sense. You have relapse or refractory disease. If you have a low-risk disease, I think you should get chemotherapy, a checkpoint inhibitor and chemotherapy. I would prefer either BV-Nivo or pembro GVD. This is obviously patients with early stage disease who presented with early stage disease, and then randomly assign the patients to either get transplanted or to get radiated. High-risk disease, and we'll just call this advanced stage disease, to get checkpoint inhibitor-based chemotherapy, and then go to transplant or to get maintenance. And I think that this is a reasonable approach, and a lot of people are kind of thinking about these types of strategies. So I think that this is my last slide. I've been studying Hodgkin lymphoma now for 33 years. I want to thank the lymphoma faculty at Sylvester at the University of Miami and at Sloan Kettering for putting up with me and doing all of these studies. We have a very large group of lymphoma docs at the University of Miami. We see 1,100 lymphoma patients a year. This is the new cancer research building. These are my 3 grandchildren. And I'm happy to answer any questions that you might have about this or any lymphoma you want to chat about. Thanks for your attention.
Thanks, Craig. It was an excellent talk. There is one question in the chat box, but I want to start off because Jacques asking about relapse disease. So I want to get through some upfront ones first, and then we'll get to relapse as you're following them. Okay, so a question about the elderly. I mean, look, just to put it out there, we don't have nivolumab registered in the country, just pembrolizumab. So the sequential approach
So for
Um,
patients with relapse
the-
disease that are older than six,
well, upfront disease. I mean, BV, ABD, BV for upfront
so if
patients.
you, so for patients with advanced stage disease, if you have brentuximab available to you, I think you should give BRICAD. I think it's superior to BV-ABD. All the drugs are approved. Um, and probably 2/3 of the patients can get away with 3 months of treatment. Now, I will say with BRICAD, make sure that you're giving prophylactic antibiotics with acyclovir and Bactrim, and make sure the patients are getting growth factors. And what I do is, it's only 12 weeks. I also get blood work once a week, and because the counts drop, obviously. And when they come in when they come in for either their week number 1, or when they come in a week later, I really think they benefit dramatically from a liter of fluid. It really gets them over the edge, and they feel much better if you do that. So that's kind of how I give BRICAD. But the results are outstanding. I mean, I don't know why anybody, if you have brentuximab available to you, I don't know why you would give BV-ABD anymore. It doesn't make any sense.
Even in the elderly.
No, in the elderly is a different story.
Yeah.
So in the elderly, if you guys have pembrolizumab, you said you have pembrolizumab available?
Pembro, yeah.
Yeah, so I would if you could give pembro AVD, that'd be great. I don't know if you can, but there is some evidence where you could initiate pembrolizumab. There's very significant synergy with gemcitabine and pembrolizumab. Significant. You could give induction pembrolizumab, and then you can consolidate with GVD, and then give some pembrolizumab after. And I've done that quite a bit. And in fact, in the patients who are really elderly, who are in not good shape, you could just give pembro and gemcitabine, and the complete response rate is extremely high, very high. And I've done that a lot for palliation of relapsed and refractory Hodgkin lymphoma, where I have nothing else to give the patients.
Okay. Got 2 more questions before we get to Jacques' one. We're a very cost-conscious, well, I mean, I think everybody is nowadays, but we are very, very cost-driven. There is some data for both low-dose nivolumab and low-dose pembrolizumab, so pembro 100, nivolo going even as low as 40 milligrams. In potentially curative disorder, I mean, do you think the data is strong enough yet to risk under treating some patients with low dose PD-1 inhibitors?
As a single agent?
Well, as a single, well, no, in combination. Well, I mean, whatever.
I would rather you give the 6-week dose, like you do in lung cancer.
So the 400 to the in pembrolizumab.
Yeah, I'd rather you do the 6. Yeah, I'd rather do the 6-week dosing.
Okay. And then just a question in terms of the emerging data of the different types of Hodgkin's, in terms of, I mean, you alluded to it in your slide on EBV and the elderly, in terms of virally driven versus oncogene and inflammatory immune escape. I mean, do you want to say anything about?
Yeah, well, that was presented at ISHL by the German Hodgkin lymphoma study group. What seemed obvious, which is obvious to everybody, was that the inflammatory component did the best with checkpoint inhibitor-based treatment. The EBV-driven ones also did better with inflammatory-based treatment, with checkpoint-based treatment, but the oncogene-driven one seemed to be almost all the patients who got BRICAD had a CR. So it may turn out that that's going to be the case. Quite frankly, with the results are so good with these programs, if you're in a cost-conscious place, do we really need to be sequencing Hodgkin lymphoma if we're looking at cost at trying to spend our money wisely? And also, quite frankly, if we're trying to spend our money wisely, when's the best time to do a PET scan, actually, right? So it may very well be that the best time to do a PET scan is not pre-treatment, right? Where you can get a CAT scan. And if you have advanced stage disease with a CT, we treat stage 3 and 4 the same, right? So maybe the best time to be doing a PET scan is to be doing a PET-2 and spending our money there. And the patients who are PET-2 negative, you can just monitor them with CTs for the rest of the time. So, I mean, I don't do that because, I just, spend money freely. But if you really had to think about it, and I always, when I lecture to fellows, I ask them, if you had to go to the bank and take the money out and pay for your PET scan in Hodgkin lymphoma, where should you? I would pay for it for a PET-2, and in large cell lymphoma, I would pay for it for an end of study PET scan. I wouldn't do a pre-treatment PET scan because I could do a CAT scan. But I want to know if I'm PET negative after my treatment for large cell lymphoma, quite frankly. So I would pay for it at the end of the treatment in large cell lymphoma, and I would pay for it as a PET-2 in patients with Hodgkin lymphoma, if that helps.
Okay. Just a question, Jacques is asking, just while we're talking about the EBV and the different subtypes, do you know the biological rationale for the difference in response in terms of why PD-1s are better in some subtypes versus others? I mean, in terms of the EBV
I
one,
mean,
why
most,
was it so marked
a lot of
versus
the inflammatory ones have a 9p abnormality, right? So that kind of makes sense. As far as the EBV-driven ones, I don't have an answer for that.
okay.
It's just that it's also enriched in children, as you know, and they do better than everybody. So I'm not convinced that EBV is prognostic, but it does seem to me that I think that this message in the older patient population with nivolumab is an interesting one, but they need to do a little bit more, basic science work to sort that out for me, quite frankly.
Okay, so then Jacques had another question about late relapse in the absence of novel agents. So we're talking the later you relapse, the better you likely are to do. Would you transplant a patient who had a relapse at 3 years and got salvage chemotherapy and followed by radiation for bulk? Again, you're starting to move away from transplant, but if you haven't given a novel agent, what's the place of transplant in late relapse?
Well, I think if somebody has advanced stage disease, if their stage is advanced at relapse, they should be transplanted. I think if somebody had advanced stage disease up front, and then 3 years later they relapse with early stage disease, I would still transplant them. But if somebody has early stage disease up front, as I said before, and then has a late relapse with early stage disease, you could probably get away with combined modality therapy, kind of like GVD and radiation therapy, probably. I think you could get away with that, but you would have to have a complete response, a PET negative complete response prior to the radiation. If it was still PET avid, I would take the PET. I don't think that radiation therapy cures PET avid chemo-resistant lymphoma. I think that radiation therapy helps cure PET negative residual disease lymphoma, if you know what I mean.
Okay. Does anyone else have any questions? Otherwise, I'm going to continue then. Do you think there is any role in this time and era for allogeneic transplant? I mean, occasionally we come across patients who've been sort of resistant to virtually everything.
Yeah, so that's interesting.
Refractory relapse disease. Is there a rationale for allo transplant?
So I think the patients have to be in CR. If they're not in CR, and getting a patient who's heavily retreated in CR is difficult. Obviously, almost all these patients will have had auto transplant would have failed. And I think you have to get them in a CR. Now, I have a patient right now who's a very interesting patient, and I can tell you that it's I'm having I'm not exactly sure what I want to do. You know, when I got to Miami, I stopped transplanting patients. I'm like too busy administratively. So I have this kid, he's like 20, he's 26, who presented with advanced stage Hodgkin lymphoma. I didn't take care of him then. He was treated with BVAVD and had a short remission duration. And then he was treated with some chemotherapy, and then he was treated with some checkpoint inhibitor treatment, and he had low volume disease, and he came to me for an opinion. And then I repeated his imaging and on a better quality PET scan, and he had diffuse bone involvement. And he really hadn't had a significant amount of chemotherapy. So I've just given him 2 cycles of ice, and he's had a near complete response. He's never had an auto, and he's never had an allo. And the question really is what to do with a patient like this. Do I believe a patient like this is still curable with an auto after having 4 different treatment programs if I can get him into remission? Or do I want to take a patient like this to an allo? My personal bias is the patient should get an allo. But I'm fighting back and forth with the transplanters about this. But I don't think somebody should get an auto. My practice has always been, since I've been doing this, is I do auto transplants in first relapse. Now, since the checkpoint inhibitors have become available, I'm willing to do an auto transplant in second relapse if they have a CR. But in greater than second relapse, I'm not really sure that it's a good idea. So I prefer to send a patient like this for an allo. I have sent, I know this is going to sound terrible. In my 6.5 years, I've sent 1 patient for an allo here for Hodgkin lymphoma. And I see at least 25 Hodgkin lymphoma patients a week. So I don't know if that answers your question, but
No, it does. I mean, just I'm saying,
but
it's
but I'm
obviously
trying to go about it the wrong way here. But I do think that there are patients who may benefit from it. I prefer drug development. I prefer to put them in research studies with novel agents.
Yeah, so the thing is we don't have a lot of access for some reason. Hodgkin studies haven't really got. We're seeing a lot more requests for studies coming through to South Africa, but we haven't actually had a lot.
Actually, I spoke with the Takeda team to some of your colleagues about trying for you all to be able to open the radar study. So I know that I know that the Takeda team is working on that, which is the early stage Hodgkin lymphoma study of ABVD versus BVAVD.
Yeah, just there's not a lot of early. I mean, they are there, but there are not a lot of early Hodgkins in.
I understand.
African situation for as I said, for various reasons. Okay, I think we are going to, if there's no other questions, we're going to close off and say thank you very much for a very informative and educational talk. Lots to take home, and yeah, thank you for.
Well, thanks for having me, and I think the slides will be available if you need them. Lots of luck.
And there's also recording of it as well, so that the people who weren't able to attend will be able to.
Okay, thanks for having me. Bye-bye.
Okay. Thanks, Craig. Thanks, everybody. Cheers. Have a good day.
Basketball courts, and I'm pretty sure I saw these on the